I shall now call upon Dr. Kiran Godse, Professor at the Department of Dermatology at D.Y. Patil University and School of Medicine, Mumbai, to kindly take this stage and share his insight on chronic urticaria in children and how to manage the same.
Hello, good morning, everybody. I thought that it won't make any justice if I don't talk 2 lines about Dr. Kiran Godse. No, I am sure that our dermatologist colleagues all know him and his work. This is basically for the pediatrician colleagues. Dr. Kiran Godse is one of the very few of 12,000 dermatologists pan-India who has taken, the name of Indian dermatology and held the flag of India to the global level, working on a very focused topic of urticaria. He is the urticaria man of India. Not only that, if you search in any global guidelines, whether that is from Europe, IACI, or that is from Germany, Gallen, or any guidelines, and search the names of the persons, you will find the name of Godse K. That is all about Dr. Kiran Godse. You are hearing now about the use of antihistamines and management of urticaria from God of urticaria. We are very lucky to have him in Indian dermatology. He is an asset to us. Please give him a very big hand. He is a very dear friend of mine. Over to you, Kiran.
Well, I am humbled and overwhelmed by Sandipanda's words, but what he has said is true. In fact, somebody said, what you do? I said, I eat urticaria, I drink urticaria, and I sleep urticaria. Since 2001, I always think of urticaria, and there are many people who help me. One of them is Abhishek Day here. So I am going to tell you about urticaria in children. Now this is the first time that I am speaking in front of so many pediatricians, otherwise I always speak in front of allergologist or dermatologist. So it's very easy, all of us know chronic urticaria is wheals, intermittent or regular. For 6 weeks or more is chronic urticaria, less than 6 weeks is acute urticaria. Now remember that eliciting, now chronic urticaria is further divided into spontaneous and inducible. But last line is important. Up to 50% of patients of CSU do not respond to therapy. What I mean is the standard dose of therapy. For adult, if you give 1 tablet of antihistaminic, only 50% of urticaria patient will respond. Similarly, in child, the standard dose of antihistaminics will not work in half the patient of urticaria. So when you write, say, syrup XYZ, 2.5 ml patient, doctor, nothing working. So please remember, only 50% patient will respond to your standard dose of antihistaminics. So that's why the need for updosing is important. So urticaria is divided into acute and chronic. Acute, we all know, you in fact treat it better than us. You search for the infection, search for the drug, search for the food and cause. Chronic is something becomes more than 6 weeks. And this is further divided into spontaneous and inducible. Spontaneous is, it comes just like that. It's speaking now and I start itching. It is spontaneous. And inducible is when patients say that, look, if I run, I get urticaria. If I sweat, I get urticaria. If I touch cold, I get urticaria. So patient knows where it comes. So spontaneous is what is the most troublesome. There are some known causes and unknown causes. The known causes are autoimmune and autoallergic and infection. Unknown causes, there are still unknown causes. So previously it was known as chronic idiopathic urticaria, but now we say it's chronic spontaneous urticaria because we know more than what we don't know. So obviously, still there are few don't know, but maybe after 5-10 years we know everything about urticaria. So easy to diagnose, difficult to treat. It is known, everybody will say Pitti, Japaki, Ambert, so many now common names, and almost half the people, your grandmother, everybody knows what is urticaria. They'll give all the home remedies. So easy to diagnose, but please remember, if urticaria wheal stays there beyond 24 hours, think of urticaria vasculitis. So with a mobile phone, please tell the patient to take 1 photograph and serial every 12 hourly. If it is there at 36 hours or 48 hours, think of vasculitis. Please remember that. Angioedema, less common in children, more common in adults. But again, if you get angioedema without wheals, think of hereditary angioedema. So this is important. So all urticaria may not be urticaria. There are a few other things which are there, but typically 95% it will be urticaria. So inducible urticaria, I will not go into it, but typically it's very simple. If patient says that I can get my urticaria at my own will, it is inducible. So patient will say, I scratch, I get dermographism, I run, I get cholinergic urticaria, I touch cold, I get cold urticaria. So patient knows how he gets it, and he tries to avoid it by not indulging into same thing. So that way patient learns, but problem comes is spontaneous. Just now I am speaking, I am scratching, what will happen? So this is the biggest fear everybody has got. My child, when he goes to school, when he start writing a paper, stress, he start get hives. What will happen to him? He will not do well. So this is what we know as on today on urticaria. This is known as autoimmune type 1, type 2 and autoallergy. Autoimmune is autoantibodies. So we always tell, तुम्हारे खून में ही दुश्मन है. So your blood has got autoantibody. These two at IgE, anti-epsilon and IgE, they keep on triggering mast cell to release histamine. Simple. We have no control. What you eat, no. So autoimmune urticaria is one of the things which you know it is approximate. We don't know 10 to 30% maybe autoimmune. And second is autoallergic. Now this is a new. What is autoallergic? It's allergy to allergy. Well, it's difficult to understand. What it means is so many TPOs, IL, so many of the cytokines, there is an anti-IgE of that particular molecule which trigger mast cell to release histamine. And traditionally is allergen. If I eat something, I scratch. If I take painkiller, I scratch. So that is classical. So typically autoimmune and autoallergic are the two common causes of chronic urticaria, which we'll discuss further. So it's a complex, you know, so many things are into play. Stress, food, drug, infection. Exam is tomorrow. Child starts scratching today. Tension aa gaya, what will happen? Morning he has got exam, he starts scratching. Very common stress can induce food, drugs and infection. All the colored food, orange, red, Chinese belt, preserved foods can trigger urticaria, infection and drugs. 3 drugs, please avoid in urticaria patients. Typically it's NSAIDs like ibugesic, ibuprofen, and other things are more for adults, ACE inhibitors and gliptins, which can trigger urticaria. And autoallergy and autoimmunity play a role. So it's a complex play which is happening here. So these are the guidelines, which are the world guidelines, very simple 3-step. Start with one antihistaminic. Now this is for adults, same you just convert it into child. So a 6-year-old child, start with half tablet of antihistaminic. I already told you, half tablet will not work. So you have to give double dose. So that is the updosing. So you need to give twice a day dose, or maybe one antihistaminic in the morning and one in the night. That is the best way, because people say, doctor, you are crossing the limit. My doctor Google says you can't give twice a day. So you give one in the morning and one in the night. If no response, make it 4 times. If no response, is omalizumab or cyclosporine. So that is what is the guideline says. So what is urticaria? Urticaria is like a burning train. It starts from here, goes there. Nobody can stop the train. Please remember that. At the end of 1 year, 50% resolve. At the end of 5 years, 70-80% resolve. At the end of 20 years, still 2% will have. So it's always, our job is to douse the fire. No medicine on this earth can stop the urticaria. Remission is on its own. To some extent, cyclosporine can induce some remission, otherwise no. So our job is to douse. So never say कि ठीक हो जाएगा 15 दिन में, 1 महीने में हो जाएगा ठीक. No, it is not like that. So we thought that chronic urticaria is less common in children, acute is more common in children, but now the European studies has clearly shown that 1.30 or almost 1% of children do suffer urticaria, and typical age group is from 6 to 15, 18. I do understand that pediatricians see a child till he is 18, more because of child is more attached to that particular pediatrician. So 1% is the population of, you will see, still see the patients. But this is a good thing about chronic urticaria in children. What is good thing? In an adult, urticaria can stay for 5 to 7 years on an average. In a child, it is on an average 3 to 4 years, 50% resolve. So chronic urticaria in children is short-lived compared to adults. Why? I do not know. So again, external causes you can rarely find. Autoimmune technology, please try to find it out. I'll tell you how to find it out. Again, food allergy is a rare cause of CU in childhood, so please don't go after food allergy testing. And obviously, the pseudo-allergens, vasoactive foods can trigger, but again, evidence is less. Infections, we all know infections can trigger more of acute urticaria, less of chronic urticaria. But again, if you find the infection, treat it. But you may not able to cure urticaria, but treat the infection, that is for fever. Do not give NSAIDs for fever, please. That is a very common thing to happen. NSAIDs given for fever and patient gets angioedema or swelling. Allergy test, no. Please do not do those skin prick tests. Do not do immunocap assay, RAST assay in a child. As it is skin prick test, you can't do in urticaria patient because it can trigger. But as such, all these tests, what it shows is your child is sensitized to 1, 2, 3, 4. It is not the cause of urticaria. See, even my immunocap assay has got 20 things positive. So positive does not mean I am allergic. If it is positive is more than 15 to 20 IU per ml, then it is most likely to be a cause of true food allergy. Otherwise, no. And in my almost 30 years, I have not seen a specific food immunocap assay positive. So please remember, don't go after allergy. Okay, allergen test, allergen profile, so many blood tests, they show hundreds of sensitization. None of them is causing urticaria unless it is very strong positive, triple plus or 3 plus something. What you can do, CBC, ESR, CRP, antimicrobial antibodies, and TTG, IgA for celiac disease, because these two are associated with it. Well, these are the foods can trigger urticaria, acute, more common than chronic. Egg, milk, soya, peanut, wheat, seafood, nuts. More of acute, less of chronic, but remember, tell the patient to avoid that. If patient says that some particular food is giving me trigger, tell them to stop. That is the best way. Autologous serum skin test in children. In fact, Dr. Sandeepan will forget, 20 years back, this paper was rejected by many journals. But Sandeepan published it in Indian Journal of Pediatric Dermatology, and that gave me fame, A German colleague said, wow, you have done this test, show me the results. So this test, now it is not of much use, we don't do it routinely, but this was the preliminary almost 20 years back. Now, who would become acute and chronic? All urticaria starts as acute, go into chronic. Which one though? We do not know. One thing for sure, in adults, 30% of acute will become chronic. But in children, it is small, around 5 to 10%. Every acute will not become chronic. And who will become chronic? We don't know. In adults, we do know. Those are atopic, thyroid, metabolic syndrome, NSAID reactivity, they become chronic. In children, we still do not know who are the one will become chronic, but it is around 10% only. That is a good thing about you. So what is difference of chronic urticaria in children as adults? One thing is shorter remission, 3 to 5 years. So at least he will be there with you for 3 years. Infection, well, please try to rule out, and angioedema is less common in children. So these three are the differential features from children to adults. Now remember, 12 years and above, 45 kg child is also like an adult. So remember that. So actually, most of them, they behave like adults. Somebody is 12 or 14 years with 45, 50, 70 kg, he is almost like an adult. So treat it as an adult only. Well, it's a bad disease because child cannot concentrate. Earlier, hydroxyzine was to be given routinely. The child used to sleep in the morning, doesn't do well in studies. Very common. And typically stress, child starts scratching. 10th exam, child starts scratching. What to do? It's very common. So complete control of urticaria is important. It's important that you must treat the disease till it is gone. And how long? Still we do not know. So we don't stop the disease. We don't say, 3 hafta medicine le lo, khatam karo. No. It will go. We don't tell the patient, take it for 1 to 2 months, reduce it, again 1 to 2 months. Don't be in a hurry to stop. Because most of the antihistaminics are safe lifetime. Modern ones. So don't worry about side effects of antihistaminics. They can be given safely. Most of the antihistaminics. In fact, levocetirizine full bottle, one child drank and nothing happened to him. Remember that. So these are most of the antihistaminics are safe lifetime. 2 differentiating features you must know. One is mastocytosis or urticaria pigmentosa. Again, you can see erythematous papules, pigmentation. This is little rare, but if you see anything, please scratch with a tongue blade. And if you see this red line like this, it could be a mastocyte. Although it's rare, urticaria pigmentosa is very common. So please think of this. And second is papular urticaria. Again, very common. Almost 10% of child have it. Exposed area will get papular lesions. Now typically this, just to tell the fact that this takes 5 to 10 years to disappear. As child grows away, it will go away. Till that, child has to take care. What care? Wearing full clothes, mosquito net, and some odomos, something like that. But these allergies will not disappear. As child grows older, this will disappear. So papular urticaria, insect bite allergy, will not go fast. So please tell the patient that you have to take precaution till he is 5 to 10 years of age. These 4 tests. Now remember, when urticaria patient comes, please do these 4 tests, that's all. Don't do allergy test, don't do prick test, don't do something, CBC, ESR, CRP, IG and anti-TPO. This will give you guideline whether your patient is autoallergic type or autoimmune type. So these 4 tests are enough, they are not, only TPO is costly, otherwise the same. IG total we do, just to tell the patient what is it. Well, atopy, almost 1/3 child will have a history of atopy, but anyway, it doesn't change the thing, but typically atopic child scratch more, so they get more urticaria. Now coming to IG, we all know it's a favorite of everybody, IG do. ID, what does it mean? Tumhare khun mein allergy hai. Well, that was what, 10 years back, but now we know it better. There is a low IG and high IG. Normal level is 0 to 100 to 150, maximum 300. So high IG is hundreds, 200, 300, 500. If it is in thousands, 2,000, 3,000, 4,000, think of atopic. But typically here you will find 200, 300, 500 allergy, IG. So it's a allergy, high allergy is a more of autoallergic type. Low IG is around 30, 40, 50, intense. If it is low IG, it indicates a autoimmune urticaria. These are rough guidelines, not 100%, but it gives you clue. And here cyclosporine works better after updosing. Now don't track IG. Patient keep on doing it every week, every month, thinking that it will come down. No need of doing it. Do it once, maybe you can repeat after 1 year or 2 years, because IG will not change. In fact, when you give omalizumab, IG will rise. So don't try to track it. Anti-TPO, little costly test. Patient will have normal thyroid level, but still anti-TPO positive, which are an indicator of an autoimmune nature of the disease. Please remember that autoimmune patients will have anti-TPO positive. So don't need to treat this. When you send it to endocrinologist, they say there is no symptom, what to treat. It is an indicator that his body is sensitized, it's autoimmune in nature. CRP, again inflammatory markers, we know in COVID. High CRP is high inflammation, you need to give stronger medicine, updosing is important, and sometimes cyclosporine omalizumab. So high CRP in urticaria indicates of high inflammation, lots of activity, and you need more than antihistaminics. Please do CBC on 5-part cell differential. Don't do on 3-part differential. 5-part differential now most of the labs have. So you get an absolute basophil count. Now absolute basophil count, it is 0 or less than 0 is a basopenia, which is an indicator of autoimmune urticaria. What happens? All the basophils in the blood, they go to the reaction site, the urticarial wheels, and they are utilized there. That's why there is a basopenia. So basopenia is the indicator of autoimmune urticaria. Similarly, eosinopenia. Again, absolute eosinophil count you can find out. Normally 1 to 6% or 500 plus above. So low eosinophil count is again, you think of autoimmune. So CBC will give you a lot of things. Raised MPV, mean platelet volume, is also indicator of autoimmune urticaria. So by doing a CBC, obviously you rule out infection, look for other things also. So this is a Italian and for children, this thing, it is same. Start with an antihistaminics. If no response, make it 2, make it 4. Now, one antihistaminic, what I mean is a dose proportionate. For 6 to 12 years, it's half tablet. For 3 to 6 years, it is 1/4 tablet. You know how to dose it. So typically, standard dose you give. If no response, you can make it double. If no response, you can consider omalizumab or cyclosporine, but that needs little expertise. But you can safely go to updosing 2 to 4 times a day. Most of the antihistaminics are safe. And how to give, I'll tell you. Now, this is what we have got. Again, please concentrate only on 4 antihistaminics. That is what you are going to be useful. Fexofenadine, bilastine, both comes in a syrup form. Levocetirizine, loratadine, cetirizine. This is what you need for treatment of urticaria. Hydroxyzine, do not give routinely in all the patients because of long-term sedation. Now, typically, fexofenadine and bilastine are truly non-sedative. So, use it in children in the daytime, and night time you can give cetirizine or loratadine. I could give safe bilastine morning and bilastine evening, no problem. But Dr. Google will not allow, and all patients say, doctor, dose is only 4 ml. How can you give double dose? So, okay, you give this thing. Because updosing is not, it's recommended by all the guidelines, but it is not recommended by any of the FDA, EMA or DCGI. So, none of the drug regulatory authorities say that you can give double dose. Only all guidelines say. So, you do this way, you do jugaad. You give fexofenadine and bilastine in the morning, cetirizine and levocetirizine in the night. So, you are not crossing the limit, but you are giving double dose. Now again, antihistaminics do not work in all urticaria because mast cell do not release only antihistamine, only histamine. It releases PAF, TNF, IL-6, TF, VEGF, so many things. And these keeps on releasing, which they keeps on giving trigger. So that's why many times antihistaminics are not sufficient, and we need to give either immunosuppressants or omalizumab to control. So that's the policy that antihistaminics sometimes do not give complete control. So again, do not use older antihistaminics. We routinely say why it is because of the side effect, impaired sleep and harmful. Most of the guidelines say that. So use the newer ones. They are safe, can be given, and they are available with syrup form also. So no problem. Last is cyclosporine. If when you give 4 times the dose and still patient not responding, it's time to give cyclosporine. Now cyclosporine, obviously you need some expertise. You can use it. There is not first thing, but you need some expertise. 2 to 3 mg per kg. The syrup liquid is available 100 mg per ml. So you can give it. It works. Obviously you can't give it for 3 to 6 months, 1 year and 2 years. But typically in 3 to 6 months you do the response. Check CBC, creatinine and blood pressure. Well, omalizumab is a biologic. It gives wonderful results as long as give. No biologics can cure the disease. Most of the biologics give longer remission and better quality of life. So please think when you give biologics, I'm going to cure urticaria. No. So typically dose is 150 mg to 300 mg. Now children 12 years and above you can safely give. In fact, asthma child trials they give it from 8 years and above. Half dose 150 mg you can give. It is available, biosimilar is available, not very costly, around 6,000 rupees a vial. It works, obviously no cure. It works for 1 to 2 months. You want to give it till it goes. That is about omalizumab. So how it works, just a small thing. It inhibits binding of Ig to Fc epsilon R1. So now this is what is the trimers and hexamer. This is a mast cell and this is the allergen. When you give, there is a release. You can see arterial hives, itch, reflex erythema. So now I give omalizumab. What will do? They will form these trimers and hexamer. So my mast cell is free. So there is no hives. So that is the principle. This is a rough principle, how it works. Obviously, exact principle even still we do not know. Steroids, don't give it routinely. The urticaria is not a safe. 1 to 5 years, it will not have safe journey like your patient kept. Sudden flares are known. Exam stress, tension, outside food, some triggers, some mental menses, just a menstrual stress also can induce worsening of urticaria. So short course of steroid you can always give. Remember, don't high dose 0.2 to 0.3 mg per kg, 5 to 10 days and stop. Don't give continuously. Again, you continue antihistaminics and addition you can give, but just 3 to 5 days, 7 days, not more. Do not give continuously urticaria, the steroids. That is what is our thing. Just for the flares, sudden flares you can always control with this. Other drugs, methotrexate, it works, but in children not many studies, so I will not recommend you. There are other drugs like phototherapy, plasmapheresis, sulfasalazine, IVIG, but again, response is weak. So you stick to just 3 drugs, antihistaminics, cyclosporine, and biologics. So last slide, we all know CIU, you are going to see more and more. 1% is what is expected, so almost 1.4 billion. So you can see how many patients you are going to see of them. Diagnosis is important, you rule out other causes. Guidelines recommend antihistaminics 2 to 4 times. And cyclosporine omalizumab is the option. If you are interested, there is a handbook which I just released, handbook of urticaria, me and Abhishek Day were both. Handbook of angioedema will be coming. This is all with international authors. No this thing. Most of the international authors have contributed. They are available on Amazon. And our Indian Journal of Skin Allergy, it's a joint venture of Skin Allergy Society and ACS by Sandeep Mandar. And again, it is freely downloadable. You can look for interesting cases. Thank you very much.